Good day to all of you. I'm Dr. Tayzon, and I'm an infectious disease specialist. Today, we're going to discuss the development of hospital-based antibiotic policies and standard treatment guidelines. And I'm going to share with you our experiences in our hospital here in Manila, Philippines. The objectives of my talk are I'm going to present a clinical scenario or scenarios that show why creation of guidelines on empiric antibiotic use is very important. And I'm also going to share with you the steps that we have taken in our institution as we create the hospital-based antibiotic policies and treatment guidelines. So let's take a look at some familiar situations that we may have experienced in the past or perhaps have recently experienced. So one situation is that there is a newly graduate infectious disease specialist who was assigned to be the AMS committee chair of a tertiary government hospital. And then when she was making her rounds, she noticed that the most common infections that she encountered regularly in the ward are pneumonia and urinary tract infections. And during one of her rounds, she asked one of her trainee, how do you decide on what empiric antibiotic should you use for your patients in the ward or even in the ICU? And she was surprised to note that the trainees just copy whatever their consultants give. And then they also know what are the favorite antibiotics of each consultant. Sounds familiar? Let's take a look at the second situation. There is a critical care physician who was newly hired in a tertiary private institution. And during one of his rounds, he saw what are the antimicrobial prescribing practices of his colleagues. And he noticed that among patients who develop pneumonia, they usually give an initial treatment of piperacillin tazobactam and then step up to meropenem if there is no response to it, and then add vancomycin or an antifungal if still no further treatment. Sometimes even the diagnostics like repeating cultures are being missed. And he was perplexed on how this kind of practice was propagated and learned that there was no guidelines on empiric use of antibiotics in their institution. So these are the scenarios that we usually see and make us think of the need for having an empiric antibiotic guideline in our hospital. But the question is, how do we create one, or how do we create a clinical practice guideline that our consultants may use in order, or even the trainees may use, so that we will know what is the best empiric treatment in our institution? So here could be the questions that you may have in your mind. What are the data needed to establish policies on the appropriate empiric antibiotic use in the hospital setting? And how do we create the treatment guidelines for use of our healthcare team? So these are very important because, this has a very big impact in our antimicrobial stewardship program. Let's take a look. Now, as I've said, I'm going to share with you what we have done in our institution or what we have been doing in the past few years. So, sharing our best practices. First, our first step is that we first identify the most common infectious disease syndromes in our hospital. And in this year, our hospital data in 2022 show that the most common infectious disease syndromes that we have are pneumonia, urinary tract infections, skin and soft tissue infections, and intra-abdominal infections. So after determining what are the most common infectious diseases that we have to manage in the hospital setting, okay, the second step is first we have to evaluate the most common pathogens of the specific clinical syndrome in the hospital with reference to our own antibiogram. Determine the top pathogens in the different units in the hospital. In our case, we looked at the top pathogens in the OPD, in the inpatient, and in the ICU. And you can also compare the data of the past year. Like here, you will see that we compare the top pathogens that we have from 2021 versus that of 2020. So if we looked at, so we will have an idea if we are having the same top pathogens in the different units in the hospital. So for OPD, you will notice that we have almost the same pathogens in the last 2 years: E. coli, Klebsiella, Staph aureus, Pseudomonas. Also in the inpatient, we have Klebsiella, E. coli, Staph aureus, Pseudomonas. And for the ICU, we have Klebsiella, and sometimes Stenotrophomonas or Acinetobacter are as our second and third top pathogens respectively. So after you have compared all the data that you have for the top pathogens in the different units of the hospital and comparing your past 2 years, you can now evaluate the isolates, the top pathogens per isolates. So first, it is very important that you know the pathogens, your top pathogens causing sepsis or bacteremia. So it's very important to get the blood isolates and also comparing the last 2 years. For example, here in the blood isolates, you can see that we have the coag negative staph, and we also have E. coli, and we have also Klebsiella as included in the top 5 blood isolates. And of course, because pneumonia is your #1 infectious disease syndrome in the hospital, we also take a look at the respiratory isolates. So for the respiratory isolates in the last 2 years, what we had, our top pathogens are Klebsiella, Pseudomonas, Staph aureus, Acinetobacter, and Stenotrophomonas multifida. And again, because our second top infectious disease syndrome is urinary tract infection, so it's very important that we also know the top pathogens from the urine. So here that we have also E. coli, Klebsiella, and Proteus, and Enterococcus. And also included are the skin and soft tissue infections. So we looked at our pathogens coming from the wound aspirate or tissue. So we have here our wound isolates and again, intra-abdominal infections. So we also look at the top pathogens coming from specimen collected among patients with intra-abdominal infections. So what is the next step after collecting all the data on what are the top pathogens per unit and in the last 2 years for comparative study? And of course, looking at the different isolates that we have that we collected from our top infectious disease syndromes. So the step 3 is that we now evaluate the effective antimicrobial agents that are available for the treatment of this specific clinical syndromes. And of course, we have to prioritize them. So we now know the top pathogens per microbiologic specimen. And now let's take a look at their resistance pattern. So here, for example, let's take a look at this table. So as the top cause of pneumonia in our institution, we have the Klebsiella pneumoniae. So looking at the resistance pattern of Klebsiella pneumoniae, we also compared the last 2 years, 2020 and the 2021 data. So we can see, for example, that there is a high resistance against cefuroxime, and then ceftriaxone, and then ceftazidime. So we now know that as we formulate the empiric antibiotic recommendation, we have to take note of this resistance pattern. So, and we can also take a look, for example, looking at cefuroxime, resistance of Klebsiella pneumoniae, we saw an increase in resistance from 11% to 18% in 2021. So it will alarm us that we might need to check into our AMS policies and see what we still what we can still do in order to educate all our colleagues with the use of cephalosporins. So as we determine the resistance pattern of the top pathogens per microbiologic specimen, we now compare it from the data of the previous year. Now that you know the top pathogens and the resistance pattern of these top causative agents of the most common infectious disease syndromes in the different units in your hospital, what will be our next step? So we integrate all the informations that we have gathered, and we now create our recommendations. So this is an example of what we have in our institution. So the data that we have, we write down the infectious disease syndrome, urinary tract infection, pneumonia. For the pneumonia, we looked at it as community-acquired pneumonia, and of course, HAP or VAP. And we have also skin and soft tissue infection. So what we did here was integrate all the resistance data that we had collected from our antibiogram. And now we created the recommendations for the empiric antibiotic use. So just to look at the specific parts of this recommendation document that we had created, first is also as your guide what you can do in your respective institution. First, you can put your name, of course, and the logo of your institution. And very important that you indicate the specific year in which the recommendations are to be used. So for the data of 2021, you have to write down that you are going to use the data that you have collected for the year of 2022. And then after that, you have to indicate the specific infectious disease syndrome. This time, we indicated this for pneumonia. And then for pneumonia, you can write down community-acquired pneumonia. And this categorization is based also on the clinical practice guideline of the whole country for community-acquired pneumonia. So in cases wherein there is a clinical practice guideline from the Department of Health of your country, and then by all means, if it's community-acquired infection, you may use the data. So here we made sure that we indicated if it's community-acquired, moderate risk, and high risk. And never forget that you have to indicate the risk factors for resistant pathogens that your prescriber should consider. For example, here, in this case, the recommendations for community-acquired pneumonia, if without risk factor for Pseudomonas, are the following. We have the ceftriaxone or tapenem, and then with an addition of a macrolide or a quinolone. And very important that you have to indicate too if in the presence of risk factor for Pseudomonas, and then you have to also write down what are the empiric antibiotic recommendations that they can use. Also, the two most common resistant pathogens that we have to consider is Pseudomonas, and then another one is MRSA. And in addition to the taking note of the risk factor for the resistant pathogens, it is very important too that you may include the duration of treatment in your document. So in this case, in the case of community-acquired pneumonia, for example, we wrote here 7 to 10 days. And we also place some caveats. For example, if there is a concomitant bacteremia and the pathogens are Staph aureus and Pseudomonas, that the duration of antibiotic can be at until 14 days of treatment. After that, very important now, the HAP and the VAP. And again, for the HAP and the VAP, don't ever forget to indicate the risk factors for when they have to consider the coverage for example, an Acinetobacter baumannii. So, and also with or without this MDR. And also, we also have to consider also where are the units wherein your recommendation should be used. So if we have patient with pneumonia as CAP, and this time in a non-ICU setting, and for example, if with risk factor for MRSA, and then we have an additional recommendation, like in this case, like an addition of clindamycin. For example, too, it is very important that they have to realize that the recommendation is for ICU patients. So make sure that you indicate that the recommendation is for that in ICU. So in cases wherein patients have pneumonia in the ICU setting and there are risk factors for MRSA, and then you write again and you include in your recommendations what are the additional antibiotics that you have to add, like for example, addition of linezolid or vancomycin if in ICU setting. Again, in summary, don't ever forget, write the logo and then write the year when which the recommendation need to be used. Don't ever forget to write the considerations on the use of antibiotic treatment. You have to look at the risk factors for resistant pathogens like that of Pseudomonas or MRSA. And then you have to also write the duration of treatment and to which unit of hospital where the patient has been admitted can you use the recommendation. Let's take a look now for the additional information that you should include in the treatment guideline. Of course, very important that we give some educational materials about AMS. What is AMS? And it should indicate, of course, that it's not only about the choice, but also the correct route, dose, time, and duration. You also can indicate there why is it important that we establish an AMS, and also what are the antimicrobial stewardship program that we have in the hospital, and also a reminder on what are the restricted antibiotics. So these are just some of the important data that you have to indicate also as you formulate your empiric antibiotic recommendation or your practice guideline for your specific infectious disease syndrome. Other factors that you have to consider that you can indicate in your guideline or in your document are, you also have to write down, for example, what are the considerations if patients have comorbidities, for example, renal or hepatic dysfunction, and also about the PK/PD of the drugs. You may indicate there, for example, when are you supposed to consider calculation for the AUC in order to give the correct dosing of vancomycin, or also the peak concentration or the trough, when are you supposed to use them. So those are the important data that you have to put or to place into your recommendations. And of course, again, as I've indicated earlier, considerations on when to use the National Antibiotic Guideline if they are available in your area. Now that we have created your document on your empiric antibiotic treatment and your practice guideline, your clinical practice guideline, it is very important that we have to first place or show this recommendation to our different stakeholders for their approval and support. And mostly they are our hospital administrators, and the different infectious disease specialists are members, for example, of your AMS and members of your therapeutic team, and also the other policymakers, because it's very important that we will have their support for proper dissemination. And once they have been finalized, now there is always the need to disseminate these recommendations to all clinicians, because they are the ones or who's going to use the guidelines, or they are our end users. And there are different methods by which we can disseminate our treatment guidelines or our recommendations for empiric antibiotic treatment. In our institution, we use the following methods. We conduct open fora for the different members of the healthcare team. We have email blasts so that they can reach all the clinicians in our institution. We also create pamphlets, booklets, and have our trainees or our resident doctors save them in their handheld devices. And also, we save them in the different nursing units of the hospital so that they can easily be used as a guide of by our clinicians. There is one thing that is very important for us to remember, and we have to make sure that this advice is also included in the different practice guideline or the treatment guidelines that we disseminate in the hospital. It has to be clear that the recommendation for the empiric antibiotic use as a treatment guideline is specific for the institution and can be different from the national antibiotic guidelines, and they can't be recommended for use in other hospitals because remember, the basis of our empiric antibiotic recommendation or our treatment guideline is based on the antibiogram, which is specific for the institution of which where the data were collected. So the clinicians or the cases, the infectious disease syndromes, and the causative agents of these different infectious diseases can be unique and very specific for that institution alone. So again, remember that the use of the treatment guideline or the national or the specific antibiotic recommendation is for that institution alone. So I do hope that we have learned a lot for this today. We hope that you remember on how to create our own antibiotic guidelines. And I do hope that my sharing of what we have done in our institution will be able to help you as you formulate your own. Thank you and good day.